All right, we're gonna go ahead and get started. This will be recorded to share. We actually are able to share all of our webinars that we have at a later date under something Elise can talk about at the end here, but under our YouTube page where we are able to list all of these. We're gonna go ahead and get started. Thank you for being with us today. We have an exciting topic and conversation with some pretty stellar members of our audience today, titled Details and Variations in ECMO Transport Programs. This is exciting to hear about for me personally, just because we have really recently, in the past 5 to 6 years, started our own ECMO transport program here at the University of Louisville Norton Children's Hospital. And so we are excited to hear what other people are doing and how the programs vary and just what we are able to learn to know what we can do next in this field. So we are able to offer CME thanks to some hard work of some of our Pedi ECMO education subcommittee members. And so if you see the instructions now, you can claim CME for this. Anything else to add right now, Elise?
Nope, that's it for now.
Okay. And this is what we were talking about, where all of our prior webinars live. We've had a variety of conversations and topics that we've discussed. You can see some of them right here. And you're welcome at any time to go back and review them. If you ever have any exciting ideas or things that you would like to see discussed in this format, also feel free to email us with ideas, or if you're interested in joining our committee as well. We will be doing a Pedi ECMO conference at the also on Sunday, and if you're able to come in person, please come. If not, we do have a Zoom link that you can at least visit from afar, but not necessarily, the AV equipment is not set up so much that we can participate so much, but the chat will be monitored still. Once again, we got that. So our panelists today, we have people excitingly joining us from kind of all across the U.S. Not quite, I guess, the whole West Coast over there, but I'm sure maybe some members on here from there. We have members from Texas Children's. We have Patricia Bastero, Cole Burgman, and Katie Doane. If you guys want to introduce yourselves really quickly. Patricia, you can go first.
Hello, everybody. Thank you, Jamie, for the presentation. My name is Patricia. I've been at Texas Children's for over 13 years, and I am currently the ECMO lead for our cardiac ICU. One of the reasons I was actually brought to Texas Children's was to start our ECMO transport program, and I'm very happy to join you today.
Very excited to hear from you. Cole?
Hi, Cole Burgman, perfusionist and ECMO, supervisor at Texas Children's. Been here since 2009. I guess that's about it. Been doing transport with Patricia for a long time.
And Katie?
Thank you so much for inviting me, Jamie. My name is Katie Doane. I've been at Texas Children's since 2018. I stayed on to do an ECMO instructor year after my fellowship, and I'm currently our PICU ECMO lead.
And then from the University of Michigan, we have Joetta Dubois.
Hi, my name is Joetta. I am at the University of Michigan. I've been here going on 23 years. I've spent the majority of my career flying on survival flight in our transport team, and now am ECMO coordinator. So I get the best of both worlds.
That's awesome. And then from our adult colleague, and here to add a lot of other key components, is somebody well versed in this field, Zakhary Bishoy.
Yes, hi, Bishoy Zakhary. I'm the medical director at OHSU, the ECMO program. I helped establish the ECMO transport program here about 7 years ago. And then prior to that, I was at NYU and helped establish their transport program as well.
I apologize for inverting your name there. I actually do know your name. Sorry about that.
Not a problem. It happens all the time.
All right, and then before we go forward, we also have kind of uniquely today some other moderators that are going to be helping lead this. We have two awesome fellows that are ECMO extra year fellows at University of or at Baylor in Texas with Katie, and they put a lot of effort into helping me come up with the literature behind this and some of the questions and case studies to ask today. And so I wanted to introduce Sarah, Nellen, and Nancy Chung, who also will be talking here soon. So we're excited to have them participate. So at the end of today's session, we should be able to kind of look at the key dynamics of different teams and how they're set up, identify types of ECMO transport, including how they're kind of defined in the ELSO guidelines, learn the processes that are in place at other transport centers, and understand what it takes to start your own program, as well as identify future directions in ECMO transport research and some knowledge sharing. So to start us off, we will have Sarah take us away.
Hey, thanks for introducing us and having us kind of be with this program and get to participate in this forum. So first, we were just going to ask everybody to kind of share their ECMO experience at their institution, including their program volume and kind of the size of their catchment area, and if you guys kind of feel like this matters to having an ECMO transport program. So we'll start with someone from Texas Children's. Maybe Katie, you can help us answer that question for here.
Sure. Thanks, Sarah. Our program definitely has a lot of ECMO experience. So I know that this institution has been doing ECMO since the 90s, but we were tasked with creating our own in-house ECMO program in 2005, I believe, and started doing ECMO transport around 2012. And Patricia can correct me if I'm wrong with any of those dates that precede me. We're currently doing about 100 ECMO cases a year, and our catchment area is a little bit hard to describe because it really varies on the need of the patient, but most typically it's going to be Texas and the surrounding states. So primarily Louisiana, Mississippi, Oklahoma, Nebraska, but we have certainly transported patients just for medical transport from Mexico, Guatemala, other parts of the United States. So a large catchment area depending on what the patient needs.
Katie, when you say 100 a year, do you mean ECMO transports specifically?
No, ECMO cases. ECMO transports, we do between 3 and 5 per year.
And Dr. Zakhary, maybe you can tell us about your experience.
Yeah, we established our ECMO transport program about 6-7 years ago. We have a large catchment area in the Pacific Northwest. There's not too many adult programs that do transport. So we do Oregon, Washington, Northern California, Idaho, Montana, and Alaska. We cover up in Alaska as well. We do a decent number of our ECMO runs are from transports. I think about 20 or 25 a year or so. Obviously varies. During COVID was much busier, but in that range.
And do you do anything for the pediatric hospital, or is that only adults where you are?
We actually have worked in collaboration with our pediatric team. They offer ECMO at OHSU, but they don't have the ECMO transport capabilities. So for certain patients, because obviously we're adult trained, so for certain patients of a specific size, and ideally receiving meds that are not weight-based, we can go to other institutions that are able to cannulate. So we don't cannulate them, but if they're cannulated at the other institution, we've gone out there and then transported the patients back to our pediatric program here.
And then Dr. Dubois.
So from Michigan, we started our program in 1985, primarily start with peds, crossed over pretty quickly to adults. Our program is peds and adults. I would say we average about 140 to 150 cases a year, and it's a good mix. I would say we're about 50-50 between pediatrics and adults. We have been doing transports since early 90s. I don't necessarily know, I can't really speak to how our transport program kind of started, since our ECMO program, I should say, started, because that was before I had came to the university. I think we've just learned as we have gone. And so now our catchment area has extended out quite a bit with our capabilities of our transport team, having a jet, a helicopter, and different ways to transport. We go anywhere, Michigan, Ohio, Indiana, Illinois, Wisconsin. So, you know, in our area. but willing to and can have that capability of expanding out because we have our Learjet.
Okay.
As we go on to the next question, I think it would be interesting if in the chat, people from each institution that are represented here write if you have some version of an ECMO transport program in your center.
Okay, so we'll go into sort of a case-based discussion. So you're getting a call from the transfer center about this patient. It's an 8-year-old male who has no significant past medical history, admitted for respiratory failure secondary to flu. 48 hours after admission, has escalating ventilator settings due to worsening hypoxia and hypercarbia. And you can see those settings there on 100% oxygen with an OI of 38. He currently doesn't have any pressor requirement, has good function on a cardiac point of care ultrasound. All parties will kind of agree that this patient is an ECMO candidate and would benefit from VV ECMO. This referring hospital does not have the ability to support ECMO in their institution after cannulation.
So anyone, next slide here, Nancy.
So this is kind of what ELSO has in terms of their guidelines for who actually is a part of a mobile ECMO team. And it's a little vague. It says that you need someone who is a cannulating provider. You also need a team leader, an ECMO physician, an ECMO specialist to run the pump, and then medical transport and EMS teams. So like I said, there's a lot of room for interpretation. So we just wanted to get a feel for how different institutions actually formulate their teams. And if you guys could share your experiences with us. So we can start off with Dr. Zakhary.
So our ECMO transport team, it's on the leaner side. We have 2 people, the ECMO intensivist, who's also the cannulator, and then ECMO specialist, who primes and runs the circuit. We travel either by ground, rotor wing, or fixed wing, depending on the situation. And so we have EMS providers join us as well. In terms of who makes the decision for method of transport, obviously it depends on the distance. Sometimes we have a preference depending on acuity of the patient, as well as patient size, and as well as patient equipment. Some of our patients are on balloon pumps, for example, or Impellas, so that makes rotor wing not an option. But ultimately, the final decision depends on the pilot, usually based on weather and fuel and time limitations for their flying. In terms of age cutoffs, we have no upper age cutoff. In terms of pediatric patients, though, as I said, both the intensivists and the specialists, their licensing only goes down to a certain age, and it does vary depending on the type of intensivist you are. But in general, it seems that we're okay as long as the child has signs of puberty and is not weight-based in their medications. In terms of weight cutoffs, we do not have any weight cutoffs. Early on we did, but we've actually found that obese patients do great, sometimes even better than normal weight patients. And so we've transported patients with BMIs over 100 during COVID, for example.
Can I clarify when you say the person that cannulates? So is it a intensivist trained physician that cannulates or a surgeon?
No, it's an intensivist. So our team is made up of ECMO intensivists of different backgrounds. So we have pulm crit care, ED crit care, anesthesia crit care, trauma crit care as well. So they're surgeons, and we're adding a cards crit care person to our team as well. And so everyone's trained as an intensivist as well as a cannulator.
And do you cannulate everyone percutaneously?
Yes.
Okay, Cole, do you want to share the experience at TCH?
Yeah, sure. So it's kind of a dependent on what the team looks like. There's always the kangaroo crew, which is a our transport team's nurse and respiratory therapist. They're always involved 100% of the time. If the patient is already cannulated, we'll usually take ideally the ECMO attending along with the kangaroo crew and 1 to 2 ECMO primers. And that's just because when we go out, we do a circuit change and it's easier to do it with a second primer there. But that's depending on staffing. The primer can also do it with the intensivist, which has been done before. Now, if we go to cannulate, then we'll take a surgeon along with us, and the surgeon prefers to have a second assist, which we've also used the outside hospital second assist in the past as well. So it can kind of be a hodgepodge of team. The team lead is usually the ECMO attending. That person will take over the lead. The surgeon's just there to put the cannulas in. The specialist is there just to run the pump. The kangaroo crew is there to manage vent and meds. And then the ICU attending, or I'm sorry, ECMO attending will dictate best preferences to manage the kid. Yes, ground is the easiest, obviously, because we'll take 2 buses, and especially if we have to cannulate. But then, depending on distance, we've actually done a hodgepodge. We've had surgeons leave early on the ground to somewhere 2-3 hours away, and they meet us there. Sometimes we beat them, and we get ready so when they get there, they can cannulate. And we've also used a third party in the past to get us all there in one airplane. We're getting a new airplane that I think will fit everyone. So our farthest we've cannulated, we had to use a third party, was Puerto Rico, and we had to upsize our plane to fit 2 surgeons and the entire team there. So that was a big to do. Age, no. Puerto Rico and a couple other places we've done neonates. I think maybe the oldest, I don't know if we've truly done an adult, but no, we've done 17 or 18-year-olds. Did a couple COVID older ones, and there's no age or weight. It's just what we get, really. And weight, I don't think so. We originally had a ECMO stretcher. Our first ECMO stretcher that we built was copied after the Hawaii stretcher, and it was great. The problem was the weight of it was about 200 pounds. So then that limited us on our weight to, I think, 40 kilos. And then if the patient was any larger than that, then we just went to the original flight stretcher, and we would just strap everything down to that. So 1, 2, 3, 4, I think I answered them all. If anybody has any questions.
I kind of have a follow-up to that. You know, we do actually have an ECMO transport team here in Norton Children's, and it's unique in the sense that we've done some primary in the field cannulations, which we'll talk about the definitions in a second, but we don't have a surgical team that's willing to leave here to go cannulate in the field for these kind of random, not that often, but important circumstances. And so I was wondering if you and you know, anybody else as well, Joetta and Bishoy, could speak to how did you, I guess it's a little bit different having your ECMO intensivist team, but how do you guys have the ability to have surgeons that can leave their post and their normal call lives and their normal schedule to then go on a transport? Was it just the establishment of a program? Does someone rotate on call for them? Is it different based on neonatal versus adolescents, etc.?
Scramble. That's what we do. Whoever is available for general surgery. It's usually general surgery since most of these patients are non-cardiac. And even if they were cardiac, since they are peripheral cannulation, a general surgeon can do it. We have taken CV surgeons once, maybe twice, but it's primarily our general, and it's they scramble, see who's available. We have a CDH program that always has a surgeon dictated for that to cannulate. So a lot of times they take that surgeon who's kind of already in an ECMO type role. And then we do a lot of local for our around Houston area. And we have some sister hospitals or other Texas Children's Hospitals, should I say, in the area. And sometimes our PD surgeons are already out in that hospital that can cannulate. So that makes it easy. They're already there.
So I've actually worked in both different models. So at OHSU, as I mentioned, it is intensivist transporters and cannulators. When I was at NYU, though, in the program we set up, there was a CT surgeon cannulator. And so at that program, whenever we got a consult, the team there was the CT surgeon, a perfusionist who was managing the circuit, and then an intensivist, usually myself. And so in that setting, we always had someone on call, both from critical care and CT surgery. That person, their duties were to manage ECMO patients as well as be on transport call. In terms of the CT surgeon availability, I'm not sure if this was helpful, but the CT surgeon was young. He was just sort of trying to establish his career. And so was very much invested in growing the program. And that may have contributed to his availability. Here at OHSU, as I mentioned, it is intensivist cannulators. So here we also have a 24/7 coverage availability. The person who's on transport call is usually the same person who's managing in-house patients. Not always. Sometimes we're able to find two different people. But because the frequency of transports is not large enough to justify having someone else fully on call, it's usually the same person. And so if they get activated to do an ECMO transport, they find another ECMO intensivist who's available to cover the in-house patients. Not ideal, but again, just not enough volume to justify having someone completely separate on call just for transport.
If I add one more thing about availability. So we don't do emergent or like ECPR transports. This patient has to be somewhat stable in the sense, so we're not going to be there in 30 minutes per se. So we'll get a call, we'll start talking to the surgery, who's available. They start looking around, they start shuffling people. But we tell the outside hospital that if you need emergent ECMO, either you put them on or we're not the right hospital, I guess, or you get them stable and then we'll come and we'll reconvene and let us know. So that's one stipulation we kind of put on an outside hospital. If you want us to come and cannulate, they have to be somewhat stable in the sense that when we get there, we kind of get there. Obviously we hurry along, but there's so many factors that can slow you down, traffic or you name it, airplane problems, staffing problems, that it's really hard to be urgently whisked away to another hospital.
I'd love to hear from Dr. Dubois, but Patricia, you also have your hand raised?
I'll wait for Dr. Dubois.
So for us, it is definitely complicated to get the surgeons' availability to leave our institution and go cannulate has always been a struggle for us. For a period of time, we were our pediatric surgeons. We always had somebody on call to do it. And then as our new children's hospital went up and capacity went up, their availability just doesn't exist anymore. And so for us, it is a struggle to get those pediatric patients cannulated. With that being said, we have a very robust flight team. And so a lot of times they will send out our flight team, which consists of 2 flight nurses, go out there, see if they can do enough vent management to get those patients back. And then we will, I don't want to say crash them on ECMO when they get here, but are beyond prepared to put them on ECMO if we can get them back. With that being said, our pediatric cardiothoracic docs, there are times that they are willing to go and cannulate a child if that child was already ours. So within our system that we did the cardiac surgery on. So we're more apt to be able to find that pediatric cardiothoracic surgeon that says, hey, I'll go. It's one of our own. We'll do that. The adult side, it varies. Our respiratory intensivists, we will get surgeons that will go with us and say, we'll put on and come back. And then some are on our adult cardiac. We want them cannulated on the outside and we go pick up. So what's consistent about our team is always 2 flight nurses and 2 ECMO specialists. Our ECMO specialists, we are a team of 28. They do neonates, peds, and adults. So they are primers and everything. So there's no differentiation in our ECMO specialists. So those 4 are consistent on every transport. So 2 flight nurses and 2 ECMO specialists. Where it varies is if we take a physician or not. On the adult side, we do not take physicians. It's just 2 specialists, 2 flight crew. On the pediatric side, it's 2 specialists, 2 flight nurses, and varies on if a physician is available to go. Most often on neonates and small pediatric, especially our cardiac pediatrics, a intensivist will go with us. But on the adult side, what we found, we were taking a physician with us. And I think as Cole had mentioned, every mode of transport looks a little bit different. And so when you add 2 teams together with all the equipment and extra circuits, it was causing issues of, okay, what do we really need to have on this aircraft to safely transport this person from point A to point B? And we found in the end that the physician really didn't have much of a role in that for us. And so we opted not to fly physicians. Now, if we do a central connection, a physician will go, a surgeon will go with us because they're centrally cannulated. But anything peripherally, we do not take them. So I guess what that team lead looks like or who that lead is will depend on what we're flying or transporting, what patient size-wise. We don't, and I think Cole and Zakhary had mentioned decisions around traveling by ground or air. Again, I think Zakhary made a great point. A lot of our adults have Impellas and blue pumps, and sometimes it's easier to put them in a big ambulance. Our pediatrics, we tend to second guess what kind of mode we want to do in the winter. As we know, like keeping them warm is very tough. We've done some transports in the helicopters, the rotor wings on small ones. And it was a challenge because you have no way to warm that baby from bedside to get into the rotor wing. By the time you're in, you get ready to take off, your heater's just getting warm only to come down for landing. Based on what we have and what we're asked to transport, we'll make our decision in terms on what mode we take. And then our weight cutoff for utilizing different team structure, it doesn't. Like I said, the only variance in our team structure will be a physician or no physician.
That was incredibly informative. Patricia, do you want to add anything before we move on?
Yeah, just a little bit to what Cole was suggesting, because I think for those ones in this call that may have no ECMO transport team right now or just starting or thinking about building one, I think something that is very different to each of us is how not only the location where we are, is the resources that each hospital may have at any given time. So when Cole was saying ECMO attending, we at Texas Children's actually have an ECMO group. So it's PQ plus PQ cardiac ICU trained people. All of those people have deep sedation privileges. And there is some of us on call 24/7. We do 7 days straight. And we are dedicated to any ECMO happening at Texas Children's Hospital. The surgeons usually are, like Cole said, general surgeons, but within the general surgeon pool is also those ones that are dedicated to either ECMO, congenital diaphragmatic hernia, or fetal surgery. And so those are the individuals that we call first because the expertise cannulated on ECMO is obviously higher. Unfortunately, and different to other institutions where I worked before coming here, our cardiac surgeons, you know, we do almost 2,000 cases, so they think it's, 1,200 cases. And so they claim they're very busy. They also retrieve adult and heart transplants. So them are sort of an ad hoc PRN sort of basis coming to us. We've done some open chest transports from out of the state flying, and so they came for whatever it's worth. A lot of the things that we also do, and I think Dr. Dubois and Dr. Zakhary will agree, I think also something to think about, because we have colleagues from Spain and Canada, so like liability and laws in the US are a little bit different. And so something that if you are in the US, you have to work on is what is the liability cover for your surgeons, their practicing areas, etc. And so, because that was something when we first built our program that was key. And I think that matters as well. And for weight, I wanted to add just to finish, we don't have a cutoff weight as of now. When we were using the very fancy ECMO stretcher, transport stretcher that we built, we did have some issues because the stretcher itself was quite heavy. And then the limitations that we've encountered over the years is with the plane that we've been having available for us. And sometimes there is a total weight, obviously, as you all know, on what can you put on the plane, and sometimes that is what would allow us to either perhaps bring a family member with us or not, or perhaps adding on how many other team members will join that transport, or sometimes even when we had to put, I have some pictures, we have time later, it's very difficult. It's not very difficult, but it's something that you have to practice before starting, is to put that stretcher with the patient and with all the equipment and the plane that you use. And we used to have a very tiny one. There's very funny pictures of Cole, myself, and others is, squatting there inside the plane. And so, of course, you can imagine that depending on the size of the equipment plus patient that you're trying to put in that plane, it might matter. So it is not outcomes related, like Dr. Zakhary was saying, but it sometimes is limited to the resources that you may have. And like Cole was saying, we don't do like immediate ECMO cannulation. I don't know how many of you have been to Houston, but it's almost impossible to get anywhere in less than half an hour. So that also is part of our day-to-day life.
Okay, so we were just going to go over the different types of ECMO transport that also defines in their guideline, specifically inter-hospital transport. So primary transport, where the team goes and cannulates at the outside facility and brings back to their hospital. Secondary ECMO transport, where the patient is currently on ECMO and transferred to a different facility, still on ECMO. And then tertiary, where hospital A has a patient that hospital B goes and cannulates, and then hospital B takes that patient with their team to hospital C, to a different hospital that has ECMO capacity. And so you guys kind of answered a lot of these questions already. And so instead of answering all of these questions, since we kind of went over them, how do you guys decide to cannulate in the field versus transporting your patients back to your hospital and cannulating at your hospital?
And of course, we can not focus on ECPR, since I think all of us would agree that's a pretty impossibility with this type of job.
Maybe Katie, we'll hear from you first, since we haven't heard from you in a while.
Sure. Thanks, Sarah. I think it's a really hard decision. We don't have a specific protocol to tell us exactly which patients meet criteria for ECMO transport. We do have protocols for the communication process to make that as efficient as possible in our transport center. I think it's a tough clinical decision. There are definitely cases that we have defined. For example, if the patient is on an oscillator, we don't transport patients on oscillators. And so if they can't be stabilized on a conventional vent for transport, then you would need to cannulate on site for that patient. Patients that are hemodynamically unstable that we've mentioned, that would be challenging and risky in transport. So we would want to cannulate them at their site. So we don't have specific criteria to say. It really varies per patient where they are, how long it would take to get that patient to us. Is our transport team available to go get them now? And as Cole mentioned, we can't really do ECMO transport in an emergent fashion. So we have to take into account technically we have an hour to give the outside facility a decision, and then we always aim to leave our facility within an hour. And then you can factor in at least, and most of the time, about at least an hour of travel, and then maybe an hour to cannulate. So there are, it takes hours to get a patient on ECMO through ECMO transport. So just keeping those factors in mind, depending on their stability and where they are.
I want to add to that question. When someone usually calls through the normal transport process and they, call about a patient, or do they, in your, catchment area of who you've worked with the most, should they say we would like to request ECMO, or is it usually kind of our sphincter tone of this patient sounds too sick for transport, we should consider ECMO?
I feel like most centers are requesting ECMO. There are a lot of astute intensivists, and they see it on the horizon. So I feel like most commonly we are getting requests for ECMO, and then they sort of leave the decision to us about whether the patient can be safely transported to us prior to cannulating or whether we need to go on site to cannulate. But usually they're asking for ECMO.
And Dr. Dubois or Dr. Zakhary, do you have anything to add to that?
Yeah, I'm happy to share. Yeah, so in terms of trying to transport patients, whether via ECMO or without ECMO, we have worked with our referring hospitals to try and consult for ECMO as early as possible. Our preference by far is to bring the patient while they're still stable, assess them at our institution, and if they
I think you accidentally muted yourself. We heard you say your preference is to bring them to you.
Oh, sorry. Okay, sorry about that. Yes. Did I? So I'm not sure where I.
We heard you say your preference is to always bring them to you first, if possible.
Yeah. So we've worked with our referring institutions to try and consult us early. It's clearly if we can transport the patient to OHSU and then assess them at OHSU, and then if they progress to make the decision for cannulation, cannulation house is always preferred. You have more resources, it's safer, it's clearly preferable. Obviously, that's not always the case. Often consults come when patients are too sick for transport, and usually that's from a oxygenation issue, that the patients are too hypoxemic. Occasionally, it's a hemodynamic limitation. One interesting thing, though, is that during the COVID pandemic, because the demand was so high and because ECMO was at capacity all the time, institutions actually started becoming comfortable, and transport services started becoming comfortable transporting patients while prone. So for ARDS, and on the adult side at least, proning is part of the ARDS protocol, and we do that before VV ECMO. And a lot of patients have a good response to proning. And so prior to COVID, transporting prone just was unheard of. But during COVID, it became commonplace. And so now, sort of an interesting corollary from the COVID pandemic is that sicker patients are being transported to us without ECMO. And so we're able to assess them in our institution at that point, whereas previously we would have had to go and cannulate them. So that kind of worked out nice in that respect.
That's fascinating, imagining that, especially since our pediatric population, it's probably much easier to transport them prone than adults. Does anyone have anything else to add? No one really asked or answered, how does surgeon obtain emergency privileges? But I don't know the actual details of that myself, but I feel like at our institution, we've always actually had this collaboration with an outside surgeon at their institution. We've never transported a surgeon, and so we haven't encountered that.
Jamie, TCH had to do that for our general surgeons, especially when we go out of state. It's usually quite fast. I don't know the details, I'm afraid, but it is feasible. But as you mentioned, I think it is key to have it, yeah.
I can share what we do. So we always have to obtain emergency privileges at the institution we cannulate at. And basically each of us has a packet, a privilege packet that we send to the referring institution ahead of us going out there. And it has all our MPI, our DEA, our privileges at OHSU, a whole bunch of information that our licenses, of course. And their CMO or AOD, depending on time of day, they review that and they grant us emergency privileges, usually but before the time we're out there.
Perfect. Yeah, seems like an easy fix.
Yeah.
All right, for the sake of time, we have a couple more things we want to accomplish here. So in this case specifically, this time you're getting a call from a hospital who's actually already put a patient on. And they had kind of an adult surgeon put a PICU patient on. And so you get a call about this patient at this point in time. It's an 8-year-old male with no significant past medical history, admitted for the flu and respiratory failure. About 4 days after admission, he's escalated to incredibly high settings, as we'd seen before. And then they were cannulated at the outside hospital. They were able to kind of manage ECMO based on some of their adult resources. So you're on day 5, and they don't think that they have the ability to no longer care for this pediatric patient. So you're being asked to come kind of do a transport on a patient that was already cannulated at an outside hospital. So does this change anything about your team personnel? I definitely think I've heard from a lot of you guys how this changes probably who you would take already, so we don't have to necessarily focus on that. But do you, decide to bring a different circuit based on what your circuit is used to managing at the bedside? Do you have any other type of special circumstances that apply to this type of transport? Let's hear from Dr. Dubois.
So for us in this circumstance, our team personnel, again, 2 flight nurses, 2 ECMO specialists, may or may not, a physician intensivist would go with us. As for our circuit management, I mean, one of the things that we do and have worked really hard on is developing we tried to standardize our process and getting intakes in on a much quicker or much accelerated pace than what we were used to. So working with our transfer center, once that initial phone call comes into our transfer center reaches out to the physician of the unit the patient would go to. Once that patient's accepted, then we do a conference call. And that conference call involves our flight program, our 2 ECMO specialists, and the physician. And then it is in that time that we have the discussion based on what's going on with that patient. So for this patient, we would ask all your, outside of the stability of the patient, the vent, nitric, drip, so forth, but we would talk to them about what type of circuit they're currently on. At our institution, we use the CentraMag for our pediatric population. And so if the patient's on a CentraMag, we obviously take ours and we would cut and switch over to our system. Adults, we use the cardio help. So if they're already in a cardio help, it's great. It just goes into our machine and we're good. So I think part of that collaborating as a team, calling for that patient report, we are able to determine a lot of these things ahead of time. So we already prepare and plan for what's needed. So that will also impact like the method of transport, right? So in that same discussion, we talk about the type of equipment, supplies we're going to need. We'll have the discussion on what method we want to take, whether it's ground, rotor wing, or fixed wing based on location. I think, in the end, what's really important in when you determine this on a patient that's already cannulated is being able to collaborate with the outside team of what they're currently on, and then knowing what we currently use, and then making a plan together with our flight team and our ECMO specialists on what that looks like when we go there. And we are pretty methodical on getting to the bedside, and one of the first things we do is change to our circuits, because if they can't tolerate our circuit, then everything else that patient's on, you just spend a lot of time changing for no reason. And so we kind of do things very routine. We go in, we get a report, look at the stability at that time, and then make the plan of switching to our circuit first. Once we're on our circuit, we're good. Then the flight crew does their thing by switching vents, drips, and other, equipment the patient may be on. But I think every situation looks different, but the key to it is that collaboration between the outside hospital and our teams together on one joint call to be able to ask all these questions. Because there's a very specific packet we use too. Like, we ask for very specific, so many blood products, these are what we need. There's a lot of prep work going into before we launch.
Okay, so we're going to switch gears a little bit, and we're going to talk about starting an ECMO transport program. So at least in the pediatric world, Arkansas Children's is one of the more established programs that's actually published a decent amount regarding their pediatric ECMO transport program and how their outcomes are actually pretty similar to their in-house cannulations, and also similar to ELSO data outcomes. So we at Texas Children's actually, I believe, use this framework or a similar framework when we were starting our own transport program as well. So our next topic is going to be, can you share with us some insights about starting an ECMO transport program?
These questions as a framework for answering things about like how you train your team and prepare your ECMO transport program, and then any advice that you would give other people. So maybe we can start with Dr. Bastero.
If you also want to tie in our next slide, which is use of simulation to establish your program and advance your program, we can hit both of them together.
That'd be great, because you have a ECMO nerd here and a simulation nerd here today. So, when we first started our ECMO transport program here at Texas Children's, it was sort of very obvious to everybody that it was a need, because there were a lot of requests for transferring to a high level of care of patients outside our institution, and the level of instability those patients were facing and the risks that they would undergo if they had been moved. It was clear for everybody. So I do think that needs assessment is a first point for everybody, and that needs assessment should go hand in hand with resource allocation, because you can decide to truly have an ECMO transport program, be a 24/7 program like ours, or based on your hospital needs, it may be sort of whenever is needed, we can gather together to support a kid, right? So the risk of the second version, I think, are that if you don't do it often enough and if you don't keep up with the training, I think there is some intrinsic risks just inherited to the fact that you're actually moving a critically ill patient. So if you don't train or you don't do it enough, potentially you have higher risk for the very infrequent but present complications that you may encounter during transport. So I think needs assessment, resource allocation, you have to speak with the higher ups, the stakeholders of those that will control the intensivist, transport team, primer team, plus minus surgeons, depending on the model. Who does their schedule? What does that schedule look like? And if you're potentially away for 8-12 hours, like some of our trips have taken, how is their job going to be covered? So I think when you start doing all of these, you have to have stakeholders from all of the different departments that would be involved. And with that, I also mean blood bank and the referring hospital's ability to provide you for transport blood and such. So I think that knowing your resources and needs assessment is key first. Then identifying people that I think for something as complex as this would be, at least in our institution, everybody was people with significant experience in intensive care already. So even We call them kangaroo crew. It's a transport, emergency transport team. There's always a nurse and a respiratory therapist. They're all ICU trained. And within that transport team, a few of them who are higher, like they're more senior, are the ones that actually would come with us on our ECMO transport. So we identify the key players, the ECMO attending with interest in going, make sure deep sedation. Sometimes, as we were discussing, we will go to the hospital and actually cannulate. And so we will have to do that. So what are your privileges, whether within your institution or outside institution? And then start parallel training and process building. Create your process map for what an ECMO transport would look like. We have 2 routes, one for when the patient is already cannulated, and another one is when we have to cannulate. And then, do tabletop sims to try and optimize all of those processes at the same time that you're training your team. We do use simulation. We do didactic wet labs and simulation-based team training. I think there is vast evidence in the literature about the benefits of simulation-based team training for ECMO. There is evidence that self-perceived acquisition of knowledge and technical skills, as long as together with that behavioral skills, it's clearly there. And then there is evidence of faster response to circuit-related emergencies. So I think, if I may, I think there is no question that simulations should be part of your process. And I would argue that simulations should be part of the process of building your program in 2 big instances. One, training the team, and another one, identifying latent safety threats within the process and the team that you've built for that. Meaning you're doing a simulation-based system testing to identify gaps in the process that you otherwise would not come across. I think that although it sounds very like too much work perhaps and a lot of time, I think nobody would regret doing it that way. So I'd say needs assessment, resource understanding, process building, and never forget any of the quality initiatives and safety initiatives that your center has, tabletop, simulation-based system settings, etc. And then definitely training. And training should be ongoing. If you do many, like Dr. Zakhary are doing, like 20, 25 a year, you may be able to not do it as often. When you don't do many, I think that training should happen more routinely. I think it was Katie or Cole saying that we're going to get a new plane. So obviously our intention is to retrain and obviously train within that aircraft, not because of the management of the ECMO transportation would be different, but to also identify potential issues before we take a real patient on a trip. And I think those are sort of the basics. Obviously, that you have to have the buy-in of the whole institution. Depending on your size, you may be deploying them of surgeons or intensivists, or you may take a transport team away from doing other transport for a long period of time. So institutional buy-in is key. And then don't forget about privileges and liability, perhaps more important in the US than other places where I've worked. I think it is also good to undergo all of those evaluations and, just touch base with your legal teams and such, just so nobody has surprises. I think part of building all of these and your own process is about having checklist. I think checklists are key. Cole and his team built pretty robust checklists for us. And the checklists are before we leave, when we're at the referring hospital, and before we leave the referring hospital. And I think there's no need to discuss the importance of those. And I would add, just to finish, that it is also important to have a dedicated person to speak to the family. What the referring team that is calling you to cannulate the patient and take them, or has cannulated the patient and they're asking you to take them to an institution, may vary. And so it's important for the family to understand risks, benefits, and what it entertains to move the patient. And I think it will all be more successful if they're a little bit more aware of that, what that takes.
I love that you just tied the family and the patient back in, because this has been a really technical conversation where we've talked a lot about teams and logistics and physician and you know, all of the team members' point of views, and we really haven't mentioned the patient that much, and how, you know, we're taking them from their home potentially into their sickest days of their entire life, sickest their family's ever seen them, and taking them away from their home through this process. And so I think that's something to remember, that is the root of why we do all of this. And, you know, standardization of care is there for a reason. So I'd love if anybody else wants to answer any of those questions, but for the sake of time, I just wanted to show this last slide in case you had anything to mention on this as well. You know, I'm very interested personally in kind of thinking about everything from kind of an ELSO registry point of view. And at this point in time, you can't answer most of the ECMO transport questions that we just asked today through ELSO, which is rare for ELSO. And so a lot of ECMO questions you can answer out of there. And so I think there is an opportunity for collaboration to create some form of a ECMO transport registry. And I would love to know if anybody knows of something that already exists or a way to look at this that I haven't heard of.
Jamie, I don't know that it already exists. I would agree with you. I think that there's a lot of lessons learned that we can do from each other. The one thing that we do that we started years ago is we do biannual simulation training with our flight team in all modes. So ambulance, rotor wing, and fixed wing, with all of our different machines. So it's mandatory for both teams, and all staff have to go through it. And it is simulation, loading, unloading, securing, everything. But the other thing that we do quarterly, we do joint rounds with our flight team and us. So every quarter we sit down and we go over every single case that was transported, presentation of the patient, lessons learned, how can we improve? So that is all talking about quality improvement. We do that internally with our teams, but I would agree with you. I think that this is something, it would be nice to have more input from not just our program. So just because we do it, there's probably a lot of lessons we can learn from other programs that are doing it, and how we can do and improve things on our end. So I would love to be a part of that if anybody does stuff like that, because I think it's really important that, you know, because everybody's got different modes of transport and everybody's got different age populations, everybody has different ECMO machines and circuits. I think that there's a lot we can learn as a, you know, a whole community.
Yeah, this is like one of my dream projects. I have another one of my colleagues that wants to do it with me as well, Dr. Kevin Havlin. So anybody that's interested in collaborating, I'd love to hit Ryan up on his ideas for Michigan as well.
Awesome.
Does anyone else have anything else they want to add? This was just like very riveting conversation. I love hearing from experts in this field and people that, you know, have really established programs that we could all model ourselves off of. And so we really appreciate your time today and the efforts you put into teaching us and other centers how to do this and how it should operate. But if there's, you know, and Dr. Zakhary, anything else you wanted to add today as well?
I'll just mention one of the most important things to keep in mind as well is just your relationship with referring hospitals. If you're looking to set up a successful ECMO transport program, it's worth time on the ground, visiting the other hospitals, giving them some presentations about what you can offer, what ECMO is, when patients are appropriate for ECMO. Not only does it improve the communication, the relationship, but you'll get more timely and appropriate consults. One of the toughest things, of course, is when we get a consult on a patient who unfortunately is, you know, too far out from their injury or contraindicated in some other fashion, and there may have been an opportunity to intervene sooner. So getting the word out about your program is very much key.
Elise, do you have anything you wanted to say at the end here?
No, I just want to thank all the panelists and moderators. This was reiterate what Dr. Furlong Dillard was saying, that it was a great discussion and we really appreciate everybody's input. We would love to hear feedback on our webinar, this webinar, so that we can continue to do them and improve them going forward. And so this QR code, if people would be so kind to take a few minutes and take a screenshot of it and fill out this quick survey, that would be really appreciated. And then, you know, it'll take us a few days to get this up on the YouTube page, but we will be putting it on our YouTube page so that if people want to watch it afterwards, it will be available.
Again, thank you to our speakers and panelists today. We really appreciate your time.